Welcome. I'm Terry Tropin, and today I'll be discussing the ICD-10-CM coding for the Glasgow Coma scale. First, let me tell you a little bit about myself. I have a master's in healthcare administration informatics from the University of Maryland Global Campus and have RHIA and CCSP certifications. I'm also an HEMA-approved ICD-10-CM PCS trainer. I worked for 20 years at Montgomery College in Maryland as an adjunct professor. I've also written some books on coding. These evolved from study guides I did for my students. So I have a book on evaluation and management coding made easy, ICD-10-CM coding made easy, ICD-10 PCS, and also a separate smaller book on the changes between 23 and 24 on CM and PCS guidelines and codes. These books are available on Amazon and they're updated every year or as needed because sometimes they sneak other changes in there mid-year. If you would like a copy of the slides for this video, like this video and send me an email and I will send you a PDF of the slides. So here's an overview of what I'm going to talk about during this presentation. What is the Glasgow Coma scale? How to use R40.2 using R40.21 through R40.223. This is the 3 elements of the coma scale. 7th digits for location where the measurements were taken, where the scale was documented. And there's also another code, R40.24 and R40.2A, and also some guidelines about documentation of the coding scale, and then I have some practice. So what is the coma scale? So the coma scale actually officially is all of these. You can see this is from the Cleveland Clinic, but the codes don't really have this one. So there's eye response, motor response, verbal response. So what specifically do we have in the scale? A patient's total score is determined by points, which in these 3 categories. The points in the 3 categories are added up, and that's the total scale. So we have eyes opening response, eyes opening spontaneously, eyes open to verbal commands, speech or shout, eyes open to pain, and no eye opening at all. You can see that the higher the points, the better the patient is doing. The lower the points, the more serious the coma is. So verbal response, oriented is at 5, confused conversation but able to answer question is 4, inappropriate responses, words discernible is 3, incomprehensible sounds or speech, and then no verbal response at all. Finally, we get to motor response, obeys commands for movement. This is movement, motor. Purposeful movement to painful stimuli, withdraws from pain, abnormal flexion, extensor response, and no motor response at all. Now you see here how this is categorized. Minor brain injury is the highest points, 13 to 15. Moderate brain injury is 9 to 12 points. Severe brain injury is 3 to 8 points. So the coma scale is found in the Signs and Symptoms chapters ICD-10, code category R40.2. So coma codes are used to report traumatic brain injuries. This is due to some outside force, like an assault, not something inside like a cerebral vascular problem. So there's something outside the body injures the patient and then they're in a coma. These codes are mostly used in trauma registries but may be used in other settings. And this is important. First code, what caused what the coma is a result of. Fracture skull, intracranial injury, etc. So that's listed first and then the coma scale. So do not use the coma codes if the patient has a medically induced coma or is under sedation. A medically induced coma is a reversible coma brought about by administration of sedatives to protect the brain from traumatic damage, since the sedation suppresses some brain activity, and that helps protect the brain. Let's look first at R40.20. So use this code in two possible situations. The underlying cause of the coma is not known. Is it traumatic? Is it non-traumatic? We don't know. It's not documented. You can also use this one if the cause is traumatic, but the coma scale is not documented, either total scale, individual scores, whatever. It's just not documented. Now, under unspecified coma, there are inclusion terms, coma NOS and unconsciousness NOS. So, coding for the scale begin with subcategory R40.2. 3 codes within this category are required. R40.21 for eyes opening, R40.22 best verbal response, R40.23 best motor response. So the verbal or motor responses or the eyes opening may change during the examination. So you do the best response that the patient had during that period, that encounter. Do not use these codes with R40.2A, which is non-traumatic coding. So this is non-traumatic. These are traumatic only. And again, never, ever, ever list these first. There are some important notes under these codes. Under R40 category, it lists examples of responses for verbal and motor responses for patients aged under 2 and 2 to 4 years old. Of course, those responses are going to be different because their verbal and motor abilities may be obviously different than an adult. Now, the 6th digit in the code indicates the score for that specific criteria. 6th digit 1, score of 1, 6th digit 2, score of 2, etc. And again, 3 codes are needed to complete the Glasgow scale. The first one I'm going to talk about is eyes. So R40.211, eyes open, never. And note under that says score of 1. The official scale says no eye opening, so the wording is the same. Some of them, the wording is a little bit different, but in this case, it's pretty much the same. R40.212, eyes open to pain. This is a score of 2. As we said, this is the score right here. And the scale says eyes open to pain and then not applied to face. So this is in the scale but not in the codes. R40.213, eyes open to sound. Coma scale, opening score of 3. And this word, they use a little bit more specific wording in the scale, although it means pretty much the same thing. Eyes open to verbal commands, speech, or shout. So it responds to sound of some kind. R40.214, eyes open spontaneously on their own. This is a coma scale of 4, eyes open spontaneously. The second set of codes describes the patient's best verbal response. This is the highest level during this period when the scale is being taken. So for the verbal response, you have R40.221, coma scale, best verbal response, none. So this is a score of 1. This one is a score of 2, R40.222, incomprehensible words. They're speaking, but it doesn't make any sense. So for ages 2 to 5, incomprehensible sounds, and for under 2, moans or grunts to pain. Coma scale of 2, and the official scale, the broader scale, it's incomprehensive sounds or speech, which is pretty much the same thing. So these codes are also used to document the patient's verbal score. So R40.223, scale of 3, inappropriate words. So there's doing words, but they're inappropriate. Inappropriate crying or screaming, under 2, screaming 2 to 5, and this is inappropriate responses, words discernible. So they're words, but doesn't make any sense. So R40.224, confused conversation, 2 to 5 inappropriate words, irritable cries under 2, and verbal score of 4. Confused conversation, but able to answer questions. Okay, this is different. R40.225, best verbal response, oriented. Oriented means oriented person, place, and time. Person knows their name and knows the names of significant others. Oriented to plate, knows where they are. I'm in the hospital, I'm in town, I'm in my bed, whatever. Oriented to time, knows the time of day, the date, and or the day of the week. So that's the orientation. So that doesn't really apply if the patient is under 2, right? So cooing or babbling or crying appropriately, if they're under 2, uses appropriate words, 2 to 5, appropriate for a 2 to 5-year-old. And this is a verbal score of 5. Finally, the third set of codes describe the patient's best motor response, or their movements. Posturing to pain includes movements or trunk and extremities, and it may include rigid body movements or abnormal positions. So what do we have here? Coma scale of 1, no motor response. Coma scale of 2, extension. You see, this is extension, so it's increasing the angle between here and here. Flexion is decreasing that angle between there and there. R40.232, abnormal extensor posturing to pain or noxious stimuli, response to pain or pinching or whatever. Extensor sponsoring to pain or noxious stimuli, 2 to 5 years old. This is a 2. That's a decelerate posturing. Excuse me. Noxious stimuli are actions liable to cause pain, like pinching, applying high temperature or low temperature. So let's look at a picture of this decelerate posturing. Notice the head and neck are arched, the legs are straight, toes are pointed downward, arms are straight, extended, and the hands are curled. Okay, so that's for that one. For the next one, we have R40.23, best motor response, abnormal flexion. Decreasing the angle between this angle here, between the shoulder and the hand in response to pain or noxious stimuli. Decorticate posturing is abnormal flexion of arms with extension of legs. And here it says spastic, and that's just muscle spasm. So flexion, decorticate posturing for under 2-year-old, score of 3, abnormal spastic flexion, decorticate posturing. So let's look at what that looks like. So this is decorticate posturing. So you have, instead of the hands being at the side, like it was the other one, you have them folded across the chest, legs are straight but rotated inward. So these are different. That's the difference between the two. So R40.234, best motor response, flexion, withdrawal. Extensor posturing to pain or noxious stimuli for patients between 2 and 5, and a score of 4, withdrawal from pain. R40.235 is also for motor response, localized pain, response to localized pain. Localized pain 2 to 5 years old, withdraws to touch under 2 years of age, and this is purposeful movement to painful stimuli, stimulus decorticate posture. So this is what we have a picture for this one. So the provider has a pinprick on the bottom of the patient's foot, and the patient removes their foot. They're responding to the stimulus of the pain by moving the foot out of the way. Finally, R40.23, best motor response, obeys commands. Provider says, move your left foot, and the patient moves their left foot. So normal or spontaneous movement, 2 to 5, under 2 years, they may not respond or may not understand, move your foot. So respond normally. Obeys commands, that patient between 2 and 5 will probably understand. And this is a coma scale of 6. This is the best, obeys commands for movement. So remember, in order to report the coma scale, you need codes from 3 categories: R40.21 for eyes, R40.22 for verbal, and R40.23 for motor. The 6th digit documents the level for the scale 1, score 1, 2, etc. In addition to that, you need to add a 7th digit to indicate where the scale was recorded. You have a 0 if it's not specified, it's not documented where the scale was recorded. In the field, by an EMT or in an ambulance, is a 1. At arrival, patient's arrival to the emergency room is a 2. Patient is being admitted to the hospital is a 3. And then 24 hours or more after hospital admission. So for each encounter, all 3 of these digits must match. That sounds like, well, yeah, but it's easy to get confused on that, particularly when they're seen in various areas. So make sure that 7th digit matches. Coma scale may be recorded multiple times during hospitalization or prior to hospitalization. It's important to get these scales so you can see the progress or lack thereof of the patient's condition. However, the guidelines say do not use the coma scale more than once during a 24-hour period following admission. List only scale at time of admission. So you can't do that second one until you hit over 24 hours. The guidelines indicate who may document the coma scale in the patient's medical record. Note that this is not in the signs and symptoms guidelines. This is in the general guidelines. It lists a bunch of other things that you can documented by non-physicians. But the coma scale can be documented by a clinician, EMT, for example. They document the coma scale. But in order for the clinician to do that, a provider must have first documented a stroke or whatever the other condition is that caused the coma. So first you have to have the why do they have a coma, why are they in a coma, and then a clinician or other person can document the actual scale. Now, if the documentation between the clinician and the provider are conflicting, ask the provider for clarification. So what if not all 3 codes, eyes, verbal, and motor, are documented? Or what if only the total score is documented? In both these cases, you use R40.24. So R40.241, total score 13 to 15, R40.242, total score 9 to 12, R40.243, total score 3 to 8, and then R40.244 says no total or all 3 individual scores documented. So if you only have 2 of the scores or 1 of the scores, that's when you use R40.244. You can't use the other codes unless you have all 3. Now, these codes also include a 7th digit to indicate where it was recorded. Now, there are other codes related to comas or loss of consciousness, and I'll go through these real quickly. R40.2A, non-traumatic coma. This is, the ones we're talking about are coded only for trauma, injuries. So R40.2A is non-traumatic coma. It could be a stroke, it could be anoxia, it could be poisoning, it could be epilepsy, etc. It's something inside the body. The other R40 codes were for outside the body, an outside injury causing a problem. This is something inside the body that resulted in the coma. You also have R40.3, persistent vegetative state. This is severe brain injury. Could be head injuries or disorders such as respiratory arrest or cardiac arrest, deprives the brain of oxygen. Patient can open their eyes, cannot speak or do things that require thought, no awareness of themselves or their environment. It's considered persistent if it lasts more than a month. Finally, we have transient alteration of awareness, a brief episode of losing normal awareness or behavior. This could be seizures, reduced blood flow to to brain with syncope, fainting, medical, psychiatric, or post-traumatic disorders. None of these codes have a 7th digit for where the patient was located when the coma was documented. Code R40.2A is a 5-digit code only. That's all there is. Codes R40.3 and R40.4 are only 4 digits. So that's all you have. So let's compare these codes. What's the difference between these codes? R40.21 to R40.24 are traumatic injuries, assault, falling downstairs, resulting in a coma, something outside the body. R40.2A, non-traumatic medical problem. So this is not an injury, this is something medical inside the patient, stroke or cerebral vascular disease, for example. R40.3, patient seems to be awake but does not respond meaningful to outside world. These patients seem to be somewhat asleep. This patient seems to be awake but is not responding at all to the outside world. R40.4, transient alteration of awareness, brief episode before returning to normal, fainting, seizures, and then after it's over, the patient returns to normal. And I have to go into saying, why did this happen? But still, they're going back to more or less normal. So, are you ready for some practice? Let me read the case, and then you stop the video to look up the answer, and then start it again to check your coding against mine. So here's the first practice. Patient admitted on Tuesday in a coma after a traumatic skull fracture. The admitting provider documents eyes open to pain, motor response, no motor response to command to move limb. So look at your books and see how you think this should be coded. Okay, first you do the code for a skull fracture. Now look, you only have 2 of the 3 categories documented, so you can't use the scale. Use R40.2443, partial score. You only have 2 of the 3. 7th digit is a 3 since documented at time of admission, patient admitted. So this is kind of a trick question. Here is another case. Patient admitted on Tuesday in a coma, traumatic skull fracture. The admitting provider documented eyes open to pain. Patient spoke, but words were incomprehensible. No motor response to provider's command to move a limb. The scale was documented again 15 hours after admission, the next day. Eyes open to sound, verbal response, patient seemed oriented, and motor response, no motor response to command to move the limb. Okay, give a look and see what you think this should be coded. Okay, so this is a summary of what we had on the other slide just to remind us. Remember, the guidelines state the scale is documented at admission and 24 hours after admission. In this case, it's only 15 hours, so you can't report this second one. It can be documented, but you can't code it. First, you do the skull fracture, and then you do the admission R40.2123 for eyes, R40.2223 for verbal, R40.2363 for motor. And you don't do the second, because it's not 24 hours yet. Okay, here is practice 3. Patient in ambulance being transported to emergency department due to traumatic skull fracture. I just did traumatic skull fracture for all of these, so that's really not our focus in this. The EMT documents eyes never open, no verbal response, no movement. After arriving at the facility, they're taken to the emergency department. The emergency department personnel document eyes never open, patient spoke but words were incomprehensible, no movement. So it's changed a little bit. So let's have you code that one and see how you do. Okay, for the ambulance, you're going to report skull fracture and then eyes, verbal, motor. Notice that all of these have the same final digit for documented in the field. And then the patient arrives at the emergency department. They do it, it's documented again, skull fracture, and then eyes, verbal movement. In this case, you have a final digit 2. In this case, you have a final digit 1. Okay, practice 4. Patient admitted on Tuesday in a coma after respiratory failure. The admitting provider documents eyes open to pain, verbal response, and motor response. Verbal response, patient spoke, words incomprehensible. Motor response, no motor response to command to move limbs. This is a trick question. I'll give you a second to look it up and think about it. Okay, this is not traumatic. This is due to respiratory failure. So, therefore, we're going to use R40.2a, non-traumatic coma due to underlying condition. It doesn't matter that the physician did eyes, verbal, motor. That's why it's a trick question. They probably wouldn't do that. But anyway, you're not going to use that. You're going to use the non-traumatic code. Respiratory failure, non-traumatic. Okay, coma coding can be confusing. Here are some possible notes to write in your ICD-10-CM book to make them a little bit easier. So turn in your book to R40.20 and write in, use if only total score documented or not all 3 scores documented. It makes such a difference to write this stuff in your book. You think, oh, I'll remember it, but you don't want to have to think about it. You want to say, oh, right, here's the note. I know what I'm doing. Particularly if you're taking a test, taking a certification exam, you just want to have the information there available for you. So turn to code R40.2 and write in use for traumatic brain injuries only. Clinician may document scale, provider physician must document cause of the coma. If scale documented admission, do not code again for 24 hours. So these are the most important guidelines we talked about. So in your book, draw a line between R40.236 and R40.24. Write in, use either all 3 above or R40.24 for total score. In R40.2a, underline the word non-traumatic in the code title. You want to make sure that you don't get confused about which are traumatic and which aren't non-traumatic, particularly if you're just starting out. Okay. Here are the books I have written. This is the end of the video. All of these books are available on Amazon. Here is the link to it. It's also in the introduction to this video. If you'd like to contact me, I would love to hear you. Let me know if there's some specific issue you'd like me to talk about. Contact me on Facebook through Tropin's Medical Coding Made Easy. Here is my email. If you want a copy of these slides, send this to this address, Terry Tropin, and I'll send you a PDF. Thank you so much for listening. I hope this was helpful.